Thank you, Doctor, for joining us in this case study video series, an educational initiative by Himalaya Baby Care. As India's #1 doctor-prescribed baby care brand, we strive to uphold the highest standards in every step of our journey. This case study, hypothyroidism, a surprising cause of Polyserositis in an adolescent, focuses on a significant subject in pediatric care. We are honored to have Dr. Durga Prasad, a senior consultant at Medanta Hospital, Lucknow, with us. Dr. Prasad will share his expertise and valuable insights from a unique case, highlighting innovative approaches in pediatric care. Let's begin this enlightening session.
Good afternoon. Today I will be presenting an interesting case of an adolescent girl who came to clinical attention with abdominal distension. What initially appeared to be a gastrointestinal or hepatic issues, but turned out to be a rare systemic manifestation of an endocrine disorder, that was hypothyroidism. This case underscores the importance of maintaining a broad differential diagnosis and not missing subtle clinical clues. A 13-year-old girl from a rural background presented with progressive abdominal distension for 3 months. In addition to distension, she experienced non-specific symptoms including loss of appetite, fatigue, intermittent constipation and secondary amenorrhea. She was referred to us for evaluation of ascites. Notably, there was no history of fever, weight loss, jaundice, dyspnea or urinary symptoms. There was no family history of tuberculosis or chronic liver disease. On examination, her weight and height were at 10th centile, suggesting chronic nutritional issues. She was at Tanner stage 2, indicating delayed puberty. She had mild pedal edema, but no pallor, icterus, clubbing, rash or lymphadenopathy. Her abdominal examination revealed moderate ascites. The liver was palpable 2 cm below the costal margin, but was soft. The spleen was not palpable. Systemic examination of the cardiovascular, respiratory and central nervous systems was unremarkable. Vital signs were within normal limits. The presence of ascites with systemic symptoms raised suspicions for chronic liver disease, Budd-Chiari syndrome, abdominal tuberculosis and constrictive pericarditis. These were the initial working diagnosis and relevant investigation were initiated. CT abdomen revealed moderate ascites, omental thickening and nodularity, bilateral mild pleural effusions and moderate pericardial effusion. The liver and spleen were of normal size and there was no abdominal lymphadenopathy. Ascitic fluid analysis showed lymphocytic predominant high protein and high SAG ascites. 2D echocardiography confirmed moderate pericardial effusion, while Doppler USG of the hepatic and portal systems was normal. And omental biopsy showed no evidence of malignancy or tuberculosis. Despite extensive testing, no definitive cause for the polyserositis, the presence of ascites, pleural and pericardial effusions was found. Common causes were ruled out like tuberculosis, liver disease, malignancy and connective tissue disorders. This created a big diagnostic dilemma, prompting a re-evaluation of history and subtle clinical features. Upon reassessment, clinicians noted subtle signs, a dull facial expression, puffy appearance, constipation and poor scholastic performance. These findings suggested a possible thyroid disorder, prompting a thyroid profile. To their surprise, the child was found to have severe primary hypothyroidism. Anti-TPO antibodies were negative and thyroid ultrasound was normal, indicating an autoimmune negative hypothyroid state. The clinical diagnosis was hypothyroidism presenting as polyserositis, which is a rare and often overlooked manifestation in pediatric patients. The patient was started on titrated dose of thyroxine. Over the course of 2 months, she showed significant clinical improvement with resolution of all effusions and normalization of energy levels. The child responded well to therapy. There was complete resolution of ascites, pleural and pericardial effusions. She is currently stable and continues to follow up under endocrinology and pediatric gastroenterology. This case emphasizes the value of looking beyond the obvious and integrating minor clues with major findings. Hypothyroidism should be included in the differential diagnosis of unexplained serous effusions, mainly when supported by clinical conditions. Thank you so much.
We hope you enjoyed this session and found it insightful and impactful. Thank you. Himalaya Baby Care proudly launches pure cow ghee range with pH 5.5, specially formulated for baby's sensitive skin from day one, that promotes skin immunity, offers an anti-inflammatory effect, protects the skin's microbiome, provides intense moisture, deep hydration and nourishment, formulated with pH 5.5. Looking forward to your valuable prescription support for Himalaya Baby Care Pure Cow Ghee range.